we cherish biodiversity in nature. We're like, great, cool, look at this rainforest. There's biodiversity everywhere. It supports the ecosystem. But it's like we forgot that exists in humans. And if you had two plants out on your windowsill, two different kinds of plants, and you put them in the same soil, same water amount, same sunlight, and if one started to wilt, you wouldn't say, you're lazy, you're disordered, suck it up, get over it. You would say, oh, shoot, I needed to adjust the environment so your biology could thrive.
Welcome to Personalized by Vitamin Lab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Deiser. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome back to Personalized by Vitamin Lab. I'm your host, Dr. David Deiser, and today I'm excited to introduce Kalin Johnson, healthcare provider, patient advocate, and entrepreneur. Kalin shows high-achieving, neurodivergent, and hypermobile individuals how to unmask their health and feel their best through concierge, whole-person care. As a licensed clinical pharmacist, functional medicine wellness coach, healthcare advocate, and neurodivergent mentor, she bridges the gap between mental and physical health through her professional and personal experiences. Kalin brings a unique and enthusiastic perspective to her private practice, a perspective gained from living a life as a queer, ADHD, and autistic individual with PTSD and hypermobile Ehlers-Danlos syndrome. She cares, coaches, and mentors with passion and an insatiable appetite to help other neurodivergent and hypermobile individuals navigate a world that wasn't built with them in mind. In her free time, you'll find her spending time with her wife Marnie and dog Yoshi at home in Nebraska or traveling around the world every chance she gets. Please enjoy my conversation with Kalin Johnson. Welcome back to Personalized. Thanks so much for joining us. I'm here with Kalin Johnson. Nice to meet you, Kalin. How are you doing today?
Nice to meet you. I'm doing wonderful. Other than it's like 110 degrees here today. Let's be honest, in Nebraska. Yeah,
oh
that's the heat
goodness.
index. I know.
Holy wow.
Other than that.
Hannah. I've only been in that heat once. I had the fortunate luck to play baseball in Boston when I was young, and I couldn't believe it. You open the door to the van and you can't breathe. It's unreal.
No, it legit sucks the life out of you. My wife is a personal trainer and she trains people out of our home gym. And I just saw her right before coming on this, and she was like half asleep, just like looked like she'd been through it, not even working out. Completely. It just takes everything out of you. So other than that, yeah.
It's funny in our region, there's this place called Kelowna. It gets that hot there, and but it's a big fitness community. So I think about their gyms all the time, but how hot it must be to train there. Unreal. I
think it's something about the mindset too of like, I know she has a lot of people in her personal training community that are like, I only want to run when it's 110 degrees outside because I need to like prove it to my body and brain that I can do that. So it goes the territory.
I used to be kind of like that too. Just
a
little,
me too.
Like, okay, let's go.
Yeah. Exactly.
Amazing. Well, let's talk about personalization in care. That's what this show is about. And I know that's what your career has been about. Tell me about the transition from traditional pharmacy to focusing on patient advocacy for people living with ADHD and Ehlers-Danlos.
Yes, 100%. Yes, happy to do so. So like you said, I came from a very traditional pharmacy background. I actually worked for about 6 years in academia, 8 if you include my residency time as well. So not only very traditional pharmacy background, but also did teaching for pharmacy students, medical students, dental, and nursing, and really found in that what was lacking in what my students were struggling with wasn't really knowledge, but was exactly this idea of personalized care, that they were really good at the facts, but then actually applying that to the person sitting in front of them based off of their individual needs, both neurologically, biologically, and socially. That was really, really difficult. And then I myself started having some health problems, both like mental and physical at the same time. Everything just kind of hit, and it kind of highlighted things for me that had always been there, always been a struggle, but I had just taken the idea of power through. That was how I was raised. That's what I was good at, was just power through. And my body wasn't letting me power through anymore. And when I sought help myself, I ended up going through a 2-year kind of nightmare diagnostic process, finding the right providers who could help me figure out what was going on. And I ended up being diagnosed with PTSD, ADHD, autism, and Ehlers-Danlos syndrome. And that sounds like a lot, but it was also all the puzzle pieces I needed to make me and what I was going through make sense. And once I had those puzzle pieces, it just opened up finally this entire world where I could actually feel good in my own life. I could cultivate an existence where I fit in biologically, neurologically, socially, all of that. And again, coming out of this, I was like, okay, like I'm a professor of pharmacy practice and I teach this stuff and I struggled this much to get the correct diagnoses and came out of it with some even healthcare PTSD from that experience. And I'm like, if I teach this and this is what the experience was like for me, how does any patient stand a chance to get that diagnosis and to come out of this not feeling worse than when they started? So that's what led me to being like, okay, I am definitely somebody who, if I spot a hole in the system, I want to plug it. I'm not okay with just sitting and letting that be. And so I said, you know what? I think from my own experience, both teaching pharmacy and then my lived experience, I think I could really, plug this hole for this really specific subset of patients.
Absolutely. You have all the experience for this. Unbelievable. Well, I'm really proud that you're able to do the work you're doing. You mentioned about this getting the diagnosis as being, would you call it freeing, liberating? What was it like? Because not everyone is out there searching for a diagnosis because it could be considered sort of a label in these 4 conditions especially. Can you talk about the difference between labels and diagnoses for you as an individual?
Completely. So the most important thing to me, and especially like how my brain works, and I really think how probably most of ours do, is to be able to help ourselves, we have to understand to a degree what's going on, the why. And the biggest thing that these diagnoses gave me was a why, somewhere to start to figure out when I go from sitting to standing, why am I feeling so dizzy? Or why in this moment where I've been sitting for so long, do I feel like I have really bad brain fog? Like I needed to start to understand the mechanism of my body and my brain to help myself. Like I even have some, providers sometimes who, when I have patients specifically, especially the EDS diagnosis, who will sometimes say things like, well, there's nothing we can do for that. Or it's just PT. And so why is it that big of a deal to get the diagnosis? One, I'm going to argue that's not fully true. It's not just PT. It's not just the joints. It's connective tissue all over the body.
It's a spectrum condition as well, correct?
Exactly that. And I even in my own lived experience, the joint part of it has actually been a pretty minimal part of my disease state. The skin and my tissue has been one of the huge issues for me. I was a rower in college, Division I rower, and sure, everybody like loses skin off their hands. I had like no skin on my hands, just bleeding, like open wounds. And my coaches were like, we've never seen this. We don't know what to do with you. And again, same thing. All I had learned having this condition my whole life is nobody can explain what's happening to me. And I just have to power through. So yeah.
Can I interrupt you there? I'm sorry.
There's
so much to unpack, and I hate to interrupt, but do you have a way of knowing if it's impacting your blood vessels?
Yeah. So that's the other part for me that's been huge, is it's impacted a lot of my blood perfusion and blood vessels and my arteries and my veins. So the thing with that we look for, especially when it comes to the hypermobile kind of EDS, is looking for signs of, I'm going to call it then POTS-like symptoms or POTS itself. POTS is a co-occurring diagnosis with HEDS, HEDS kind of being that umbrella diagnosis. One of the hardest things, though, about EDS is because that's the core piece of it, and because it is so dependent on different variables, depending on the day, a patient may or may not test positive once they go in for a POTS test. And if they don't test positive in our traditional healthcare system, they aren't really given any help.
Right.
And it's just like, I have my own sister, she went in for that test and, they're looking for a difference of a change in 30 millimeters of mercury in the blood pressure, or they're looking for that change in the heart rate. Her change was 28.
Okay.
And at 28, then they said, you don't have POTS.
No diagnosis. Yeah.
Bye. Nothing to offer her. So that's where, for me, then, the term I use in my practice when patients come to me is from their experience, and they are, quote, unexplainably unwell. And I love working with people who are, quote, unexplainably unwell.
Completely.
And finding ways to help improve their quality of life. So yes, I did find that it affected my veins, arteries, blood perfusion. Actually, standing as a pharmacist was one of the places that I was very quickly out of pharmacy school noticing my symptoms growing worse and worse. And I didn't know why. I would have issues with my vision. It would go blurry. I couldn't hear. I would feel dizzy. I would feel sick. I was having terrible GI symptoms. I was having GI bleeding, all of these things. Yep. Because my sympathetic nervous system was always in this activated state, trying to get blood to the upper part of my body and fluid to the upper part of my body. But because our veins and arteries are just like these loose noodles, I think of them like little spaghetti noodles, it has to do extra work to get it up there. And then there's this really cool if you're a nerd like me, not cool if you have an EDS body.
Strange talking about physiology in front of someone who's unwell. Very cool for me.
It's
terrible
super cool.
For you.
Yeah, exactly. But there's this cool thing called the aldosterone paradox that happens where fluid and blood flow tend to sit in the lower half of the body in an EDS patient. And it's really, really difficult, again, against gravity, for that to work its way up the body. So because the kidneys are in that lower half of the body, the kidneys think you're fluid loaded. So they start over-diuresing. So you start peeing out way more fluids and electrolytes than your body actually needs to have. So you need that volume to actually help keep those pressures up as well. But because of this aldosterone paradox that happens, we think that a lot of EDSers are walking around with about 20% lower fluid volume than they should have at any given point during the day, which also then drives home even more of these blood perfusion type issues, which if you think about somebody who's having a blood perfusion issue, who's dehydrated, even if they're drinking enough water, sitting in a chair for long periods of time, what kind of symptoms are you going to see? You're going to see things like brain fog. You're going to see things like they can't focus. You're going to see things like they want to get up around and move around. And you think about that in a kid, well, what does that look like? That looks like ADHD.
Right.
And it is from the symptomology, but the mechanism, the why, again, which is why the diagnosis is so important. So even with kiddos, where I am a huge advocate for my patients who have EDS getting their kids diagnosed too, that completely changes our realm of, options to help them manage those symptoms, as it's not even just dopamine, that the blood perfusion is a big part of that too.
Right.
It's a long-winded answer, but
no, but awesome. And bring up lots of good questions that I could be asking. We have to take a step back before we get into them to finish on the label part. Say someone is diagnosed EDS and they're sitting in front of me, for example. My experience is so minimal in these conditions, in EDS especially, and in POTS. They've gotten a diagnosis. They've gone, like all patients do, on WebMD or Cleveland Clinic site or what is considered to be a reputable resource, and it says no treatment, right? Or it says physical therapy. Yep. And then they're sitting here. How do we start? Where does the conversation begin with this patient population?
Yes. Wonderful question. So what I do at the very beginning, I call it taking a stress inventory. And I'm taking an inventory of anything that I can identify that is going to stress out the body of my patient or the mind of my patient. Because when it comes down to EDS, we are looking for anything that is going to divert the nervous system from being in our parasympathetic, calm, rest and digest state into this activated state. Now, there are hundreds of things that can do that, both physical, mental, emotional. I look for the top 5. So the top 5 dysregulating factors of the autonomic nervous system are going to be pain, dehydration and electrolyte imbalance, hypoglycemia, non-restorative sleep, non-restorative rest, and emotional and physical stressors. So running through those, that is the best place to start in starting to just talk through a patient's day in what is happening there in that setting. So I'll give you an example of one patient I had with that, where one of the main stressors she named for me was when her kids got home from school and she was cooking and she was in the kitchen, she was like, I get really irritable and I like lash out at my kids in a way that I don't want to be. And that is a huge stressor on me emotionally and physically. I feel overwhelmed. I feel like I'm a bad mom, all of these things. And at this point, I was suspecting possibly some EDS, but we hadn't had the diagnosis yet. So I started asking about other times during her day when she felt calmer with the kids. And one of the things I was able to pick up on in talking through that stressor then was she only was having these times where she was lashing out at the kids when she had been standing in a prolonged upright position for long periods of time, which is a common exacerbating factor for EDS symptoms. So that was actually the linchpin that led me down into, okay, this is what we're dealing with. And so for her, again, it's managing though any of those stressors through how we care for the body, which is in a very different way than you would care for a biotypical body. So for her, it was like, okay, maybe we don't stand as long then in the kitchen. Maybe we have a chair that, or something you can roll around on, or maybe you're only up for certain periods of time, or let's try compression garments. Let's try electrolytes to help increase that volume. Let's also try, we can try meds. We can try stimulants, which help with that blood constriction. We can try clonidine, which helps with the noradrenergic POT symptoms. Again, all these different things then that we can do to help that stressor.
Absolutely. So starting with the stressors, I like that. Okay, that makes total sense. Is there a next step once the stressors are under maybe control, or you've got some strategies? What are we looking for holistically in this patient population?
Yeah. So my approach to this, and what I think also has probably been a little bit different in my practice from others, is I rate all of mine then by patients' perceived quality of life. That's what I track most closely. I tell my patients from the get-go, and I remind them that I have no authority to name what kind of help is helpful to them. And I don't have the authority to say when they feel better and when they don't. And that is what they get to tell me. So that's really kind of the step from there, is I have them fill out basically a CDC quiz every couple of months on rating their quality of life. And, I had a patient the other day who is doing amazing now. And her family was like, oh my gosh, it's so great that like you're better, that like you're not sick anymore. And she was like, no, like I still have this. I've just now been able to curate a life that supports the reality of my body that I now understand that I didn't understand before.
Yeah, that's a really good point, and a great example to highlight it. We can get so caught up. I can get caught up in the objective data.
Yep.
Right. What are we tracking?
Exactly.
We have to be, evidence-based for the protocol, track this thing aggressively.
Yep.
But what matters is quality of life. How are you feeling? How are things going?
Yeah. And I think, again, vice versa, I think that's what's so important with ADHD, autism, PTSD, and EDS. I think that's how my practice ended up finding all of those conditions specifically. And I'll say the new type of patient I've been getting a lot of are patients with either diagnosed or suspected long COVID, because I think as well falling into a similar boat of sometimes not testing, or we don't have adequate tests for the objective data, but they are subjectively still coming in and saying, but I don't feel well.
Yeah.
But something's different. Like I'm so fatigued in a way that I wasn't before. My brain fog is so bad. And for me, that excites me. And that's where I'm like, yes, like I will help you. Where our, again, traditional healthcare system says, if I don't have that objective data, I don't know what to do.
Yeah, completely.
And sometimes I don't know what to do, but I always say that I'm willing to be a thought partner. and to try.
Definitely. Well, I think that these conditions, can be supported by primary care pretty well, but we need to have all the information. We need to not necessarily be absolute experts, but know how to personalize programs for people as much as possible. What else do clinicians need to know about the conditions that we've spoken about today? We've talked about EDS a bit already, but maybe some of the other conditions. What are the things that we might be missing?
Yeah, no, really, really great question. So I think especially kind of similar to what we talked about with EDS, with ADHD and autism as well, it is believing the patient's subjective experience, or even more than believing, trusting the patient's subjective experience. So notoriously, the diagnosing ADHD and autism has been from a state of the external observer. So the criteria that we were looking for is how I experience you as the autistic person or the ADHD person, but not how you experience you. And that is a huge difference.
It really is.
In that importance, because so that was me and a lot of my patients. If you check on my website, I describe the patients that I work with too are notoriously high achieving, high masking, so the term masking basically means that you have been able to often hide those struggles because of your ability to come up with coping mechanisms to be able to blend in, to kind of be a chameleon.
High masking. Never heard that term. I like it. It's now part of my vocabulary.
Good, excellent. You are so
masking.
Welcome. Yep, high masking. So we tend to be ones that are especially, missed. So I know this surprised a lot of my providers and even people, friends and whatnot as well. But I had a feeling I was autistic back in my teens. I used to say to my mom that there were certain things I did. I was like, it's like I'm autistic. It's like I'm autistic. But I didn't think I was because I didn't struggle in things like school or sports. So even myself at that point, that was kind of, and it still is, people don't get diagnosed if their struggles are not noticed by the rest of the world. I did have really intense struggles. I had a lot of anxiety. As a kid, I was very black and white. I was so overwhelmed by not being able to transition from task to task that when I would get home from school, I would get really upset. If anybody talked to me, anybody just tried to distract me, I would sit down and I would do my homework right then. Because if I didn't, I knew how hard it was for me to get going again. And I started that as young as 9, 10 years old. I was just really insanely disciplined, but that was the only way I knew how to manage my ADHD and autism. But I got great grades. I did amazing in school. I was good at sports. So people are like, well, you're fine. So that's not a big deal. So I think that's the biggest thing I would tell clinicians is to trust your patient's experience. And again, even I had my PCP who I absolutely love. But when I came in and told her about my autism diagnosis that my psychiatrist had seen in me, she said, but you're one of the best communicators I've ever experienced, that I've ever talked to. And so again, this kind of idea that just because we are high masking, high achieving, that we then couldn't also be autistic, ADHD.
Yeah. Right. This is something that would be such a challenge for a clinician, especially with not much time. Even in your case, the person seemed to really know you, and still wouldn't have gone there. So listening, asking the right questions, being open, communication in these settings is not the easiest thing. I'm learning a lot here, by the way. So my experience has been I have tons of experience in ADHD, of course, as many people in my city with that diagnosis, and we support them nutritionally. But in EDS, the last person I met with had to go to Europe to get good care. They ended up getting great care, but they had to leave the continent for care, which I thought was such a sin. I felt like it was a failure on my part.
Completely. Yeah.
You have lived experience. Where was someone without lived experience? How do we get caught up? how is this? Because, okay, so last night in preparation for this podcast, I recognized that 1 in 5,000 people in the United States have EDS.
Yeah.
That's so many people.
It's so many. That is what we keep coming back around to is like those, and I'll tell you, right now the Olympics are going on. I can't help but spot everybody's like them. Those extended joints.
You're like calling
narrow
them,
palate. Yeah, exactly. Being like,
Coach,
if you haven't hit the fan yet, please support their joints. Exactly. So yes, you start seeing, once you get that diagnosis, you start seeing it everywhere. And that, it really is quite common. And so I think a lot of the catch up, and I think where the struggle comes from, I always say I'm going to get this tattooed on my forehead, is that you cannot silo care. You cannot silo, especially neurodivergent or biodivergent care. And biodivergence is the way I like to, again, describe a lot of what we experience then with EDS, because there's this idea too then that we can't thrive. And I'm of the belief that we can. It just takes a different set of criteria to care for our body. So, we cherish biodiversity in nature. We're like, great, cool, look at this rainforest. There's, biodiversity everywhere. It supports the ecosystem. But it's like we forgot that exists in humans.
Right.
And if you had 2 plants out on your windowsill, 2 different kinds of plants, and you put them in the same soil, same water amount, same sunlight, and if one started to wilt, you wouldn't say, you're lazy, you're disordered, suck it up, get over it. You would say, oh, shoot, I needed to adjust the environment so your biology could thrive.
Yeah, that's a good point.
And that's the big place that we really need to start in caring for an EDS patient. So I think the way we catch up is one of my big hopes is that we do have somebody, some sort of provider who can really think holistically, who can think from this mindset of how everything plays together. I see EDS care really struggle when you are siloed off into go see a neurologist for this, go see a nephrologist for this, go see the cardiologist for this. You got to put the whole picture together. The EDS body is like the ultimate example of physics of for every action, there's an equal and opposite reaction. For everything you do to help one symptom, you are likely going to cause good and often bad things in another system because the connective tissue, what's the quote? There's a physician, Heidi is her first name. Can't think of her last name, but she always says, if you can't connect the issues, think connective tissues.
This reminds me so much, when you talk about neurodiversity and biodiversity, I mean, you have to tap into your own experiences to be able to communicate effectively when you're speaking about these two ideas. Like we measure metabolism in our practice. People come here because they think their metabolisms are low, and often it is, and sometimes it's not. And sometimes it's ridiculously low and we didn't expect it.
Yes.
Everyone is so incredibly different. It's unbelievable. And so we should expect the exact same thing with the development of our nervous systems and our mental emotional capacity and our ability to tolerate experiences, the experiences that we have in this world. Where does nutrient deficiency come into play in these conditions? Like, so with metabolism, for example, we find everyone's so different. Of course, we can find nutrient deficiencies quite often. We'll sort that out. We'll sort out the impacts of those nutrients on the different aspects of physiology that influence metabolism. I feel like this is a good in to talk about these conditions. Do nutrient deficiencies play a role?
Yes, massive role. So when I'm taking a stress inventory, nutrient deficiencies are one of the stressors I'm looking for as well.
Okay.
And looking for why, where this impact might be coming. So one of the big things I look for in my EDS patients is thinking about differences in or struggles in gastric motility, because that itself often is a problem. And then GI absorption ends up being altered because of those changes in gastric motility, and also the change in the basic to or acidic environment of the gut. Because when your nervous system is constantly in this activated state, we divert blood flow away from the gut, which ends up making the gut more basic. The gut's more basic. It's not going to be able to work through any of the food that's in there at the rate that we want it to. So that food starts to sit, it starts to ferment. If you think about that jar of sauerkraut that you open and it pops and all that air in there, basically that's what's happening in the gut. So in that time frame, then, yes, we're having major issues with GI absorption, as well then as nutritional deficiencies come from lots of different areas. So that's one of them, even just the absorption part. But with especially autism, I see it with ADHD too, sensory sensitivities. I have a lot of patients who have worked with nutritionists before and have had some good experiences, but a lot, unfortunately, have had some really not so great experiences because they did not feel that their sensory sensitivities were believed, honored, validated, that they were very much dismissed and like, well, you just have to do it.
Right, like around food texture or
Yeah.
what is that what it's around?
Yep. Food texture, food smell, any part of the sensory piece of it. It could be any of those things. And for a patient specifically with autism, we know that when those sensory sensitivities are aggravated, when we look at the brain, it is the same as experiencing physical pain. So to me then, like, again, this is why stress inventory, when I have a patient come to me and says, and I'm like saying, okay, hey, let's get a lean protein in, like maybe let's have you eat some sort of salmon into your diet. And they're like, the smell makes me want to gag. I can't handle the texture. It's too mushy. Sure, I'll come up with other ways. Maybe we could cook it, add it in. But at some point then for them, if I'm worried about the stressor of their diet and I'm adding something in that is causing a stressor that is equatable to physical pain, I just scratched the board and I'm not putting them in any better situation than they were in prior to working with me. So I have to consider, again, this whole holistic point of patients' preference. Preference is how about sensitivities, like really, truly, or intolerances, not even just preference. So that's another area. And then, yes, there are huge then issues too with like EDS. We know one of the things that we're looking at are differences in how we metabolize or struggle to metabolize folate. So also, like, you may have a folate-rich diet, but in EDS, we're finding that the body isn't necessarily always able to metabolize that efficiently. So it's not really able to use it. So where we need to then sometimes supplement with methylfolate, which is the already metabolized, broken down form of that the body can utilize. So then we've got kind of the genetic tie-ins that come with the EDS that also are affecting other nutrient deficiencies too.
Vitamin Lab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and Vitamin Lab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
Yeah, super interesting and exciting for practitioners to have opportunities to support people. In our region, they have gotten rid of, conventionally, the conventional lab, gotten rid of the folate test.
Yeah.
So we don't even have a test for folate. So it's a genetic, is it MTHFR COMT in EDS? Okay.
Yep.
So it's a methylation issue.
Yep. Exactly.
Okay. And is it, do you know how prevalent this presentation of the SNPs is in this condition?
So we're not for sure. There's just some really early data, especially coming out of Tulane University here in the States, down in Louisiana. They've got one of the best EDS clinics here in the States, and they've been kind of the ones up and publishing a lot of this. And there was their paper that came out discussing this link that possibly is there even this component of at least some people with especially hypermobility, Ehlers-Danlos syndrome, being caused then by this folate deficiency, this inability to methylate. And so pretty quickly they were looking to supplement then methylfolate, at least considering that in their HEDS patients. And I'll tell you the ones that when I'm looking for, do I think this will be helpful in those patients? One of the things I like to look at is the ferritin.
Yeah.
So I have a lot of my patients who come in with maybe borderline anemia, not quite anemic, but really, really low ferritins. And that's another piece of objective data, though, where I found traditional medicine, even if it is really low, they're kind of just like, yep, it is what it is. Like, you're not anemic, so okay, or here, take some iron, but it doesn't really do much. Plus that comes with a lot of adverse effects. So that's a patient automatically that I'm going to start thinking about, okay, are we having this issue with folate? Are we having issues methylating that? Do we need to try a methylfolate? And that unto itself, that was me. My ferritin got down to 6. And I was having a hard time like walking up the stairs. I couldn't hold my body upright. And again, I was running marathons to feeling like I couldn't walk up the stairs.
Wow.
And same thing, they were kind of like, we don't know what to do. Or they did iron infusions then, but my hematologist was like, your ferritin dropped the fastest I've ever seen anybody's drop after that. And of course, looking for bleeding, no signs of bleeding, everything's fine. Started taking methylfolate, and now my ferritin's in the 50s, and I was finally able to get pregnant. That was a big thing. I'm 25 weeks right now, but
congratulations.
Thank you. But we think that low ferritin was a big cause of why we struggled for a while to then get pregnant. So
absolutely,
all tied together.
Okay. Do we know why the methylfolate helped maintain the ferritin levels? Any mechanism that you know of?
No, and I've played around with different theories, but honestly right now, mostly theoretical. So no, not for sure exactly.
You know, in our region, there's so much depression and low energy, just given that greater than 50% of the population is deficient in vitamin D. They take vitamin D and iron and B12 incredibly seriously, conventionally here, but other deficiencies, maybe we see a little bit of zinc tested around here, but nothing else really considered. Any other patterns in these conditions we should look out for? Is vitamin D, can that be an issue? Anything else you can think of?
Yep, vitamin D is a classic one. Magnesium, also magnesium deficiencies, that's huge. So this is, I guess, a little offshoot of this, but just I think a really relevant pattern that I want to throw out there too for clinicians to consider is also the role that histamines play. So another thing that we see then is in autism specifically, we know there's a higher correlation of this. We don't know necessarily with ADHD and EDS, but we also know that there's a lot of autism cross-correlated with ADHD and EDS. But in autistic people, they're more likely to have this genetic difference. And I don't remember the SNP right now, but I can send you the article too, if it helps to put it in the show notes as well. But basically, that people who are autistic have this genetic difference to where their brains do not metabolize, do not utilize, do not get rid of histamines efficiently, specifically in the brain. So you are going to see more neurological symptoms aligned with increased histamine release.
Wow.
So things like anxiety, things like depression, things like changes in mood, all these things that a lot of times we notoriously just throw with autism. Or I get a lot of patients who have been like, I've been seeing psychiatrists for forever and I'm not getting any better and I don't understand why. That's another thing to look for. And one of the things that we sometimes supplement those patients with is quercetin. So that can be really, really helpful in stabilizing the mast cells, because mast cell activation syndrome, MCAS, is also a really common co-occurring condition with EDS.
It's so prevalent here. Unbelievably prevalent. Okay, so strategies for assessment. I'm interested in. We do a blood test, but this is not going to tell us, the blood test for histamine is not going to tell us about the histamine that's hanging around in the brain. Nope. You know, we test for the enzyme in the gut that breaks down histamine. We test for total IgE. We can't see locally. We can't see what's happening in the tissues.
No. So a big part of what I end up basing that off of is symptomology. So is looking at a lot of what's occurring and trying to find correlation also with timing. So like I have a psychiatrist group here who uses me to consult with, and that's one of the things they have me looking for most often is in their ADHD and autistic patients, also looking for, do we think histamines are playing a role then in their uncontrolled anxiety, depression, any of those things. And so I will tell you, like, so I think I mentioned before that like my mental health was really struggling at the same time as my physical health. Well, that was why I finally was able to correlate that specifically when it got really, really bad. I was unfortunately experiencing suicidal ideation, which would only come when my histamines would flare, when I was having these allergic reactions. So that was one of the ways that I still kind of look for in my patients. Like when they come in and they're saying, hey, I'm feeling down, I'm feeling all these things, I'll start asking, okay, did you have any exposures to any of the things that we know you're sensitive to? Most of my patients, I will at least mention the idea of going on a low histamine diet, or at least finding and spending time to see if there are some core foods that may be aggravating that as well. But the nice thing then about this too is it can be a pretty low buy-in. So sometimes in those patients, I'll be like, hey, okay, I have one who we're doing this with. I'm like, she wanted to try loratadine. I was like, let's try loratadine for a couple of months and let's just see what happens with your anxiety, depression. Let's see if we see any improvements. And so sometimes it is a little bit of a kind of, let's wait and see.
Yeah.
And
the experimental component to it.
Exactly. Yeah.
I tried it this weekend with an adult onset shrimp allergy and I had a terrible weekend. Absolutely terrible. I can't believe
awful.
it. It's so sad. You know?
It's so
no
sad.
more shellfish for me. I'm from the Maritimes.
What are you going to do? I know.
But thinking back on it, not to equate myself to people who have gone through really difficult things, but I did have anxiety this weekend. With a huge histamine response, which I dealt with for 48 hours because I didn't suppress it. The anxiety was outrageous. So assessing for IgE reactions to foods could give us some indication here. I've done on a complex chronic disease patient one time, a very comprehensive IgE test where there was sort of like 8 different types of tomatoes and one of them came up.
Yeah.
You know, like 10 different potatoes, one of them came up. Like you can find things on these comprehensive assessments. Would that be part of your repertoire, looking at this type of detailed allergy assessment?
Yes, that would definitely be something that I definitely recommend patients to do, especially, you know, one things I really strive in my practice to do is being able to work with patients of all types of, I guess, financial abilities. And also here in the US, obviously, things being covered, not covered, and how much things are can also be a big hindrance. So, so for patients then who are able to go ahead and afford doing that testing, that's definitely something I recommend. Or as well, going through, even at least at the allergist as well, doing a scratch test or a prick test, as well as a patch test, which is something that's not readily as done in those offices or immunology offices. But one of the things that can be really triggering histamine-wise for a lot of EDS patients are more things like preservatives that are found in different products. So beyond like foods, and those can be really, really hard to identify. That was, you know, my symptoms got really bad at the height of COVID, and yet I hadn't had COVID, and I was very confused. I was waking up every morning looking like I'd been stung by a bee. Like my eyes were all swollen shut, like my lips were swollen, my cheeks were swollen, and nobody could figure out what was happening. Once we figured out the EDS diagnosis and I had done the patch tests, found out that there was a preservative I was allergic to called methylchloroisothiazolinone. And it's found in a lot of cleaning products. So the fact that everyone was wiping everything down more, I was now getting overexposed to this allergen that I had just hadn't. It kind of shows you how probably dirty everything else was prior, that I wasn't getting.
Just an abundance. Part of it is just a threshold, right? Like it's just so much cleaner, so much all the time.
Yep.
Oh, I did my patch test training and I feel like there's so much potential for communities that are struggling, but there's no patch test clinics here and I'm not set up for it. I feel terrible about not being able to offer it in a complete way because I think it could be so valuable.
So helpful. Again, especially for EDS patients. That's where I see things come up the most positive often that can really, really be helpful is in the patch test. Yeah.
It's a different type of response.
It is.
It's funny. Our immune systems are so complex. It's such a struggle to be, especially without any testing. Take courses like in MCAS, right? Like we see so many patients, post-COVID patients with elevated histamines and people with recent diagnosis of MCAS, and we're doing antibiotic therapy and we're doing quercetin and comprehensive protocols, and very often not able to do a ton of testing, and it can be a real struggle. But your point about quality of life and tracking and simple things, I worry about elimination challenge diets, low histamine diets, and not being able to have enough sensitivity in the experimental approach to know what made the biggest difference.
Yes. Okay. So you were exactly right. So when I'm looking at stressors any of the time, I always say I put it in two buckets. So the ones that are impacting you the most, and then the bucket also of the ones that you are most willing to change. So sometimes, again, those don't cross over. And again, that can create a new stressor itself. But you are right. That can be really difficult. And I will say I am not a fan of any full elimination diet period. I just find, behaviorally, that's not something that ends up working for most patients. I also come from, a family where there was a lot of, eating disorders and disordered eating present. And so I'm definitely very sensitive to like my patients and being careful around a restrictive mindset when it comes to this, which is really hard to balance when you have conditions where you may want to make adjustments in dietary things as well. So I have like a general list that I have with my patients of kind of like, okay, here are low histamine foods. Here are kind of the safe ones. If we can fill most of your day with that, we will be better off, period. So maybe we're not eliminating these others, but we are lessening the stressor chance if we are filling more of your day with foods that are low histamine than those that are going to be moderate or high. And once we kind of establish that, then sometimes it can become a little more obvious around what are those triggering foods. That's how I've been able, even in my own life for myself, been able to find that, because I'm really good at being restrictive. And it's something I had to balance in my own life. So filling that more, again, my diet with low histamines, and then maybe when I go out or on like weekends or something, I'll have some avocado, which is a high histamine food, and really spot and see, okay, what happens? And becoming, so much of improving quality of life for EDS, ADHD, and autism is really about being an observer of your situation. I always say that like I'm a researcher, which also helps me not beat myself up when I quote mess up. So I ate the avocado and my stomach is a mess for the next couple of days, and I'm having like rashes on my face, and I'm, having hives and whatnot. It's so easy. My patients too will just beat themselves up of like, I messed up. And it's like, we create a hypothesis as researchers, and we don't judge that when the results come through in the discussion. We may say, hey, here's what we're going to do different next time. But then we step back in and we try it again. Right. And that's what we have to be in our lives as patients with EDS.
Yeah, definitely. Okay, that's a really great way of putting it, Kalin. That helps a lot. I'm going to have to use that to justify not being able to play with my kids this weekend. I'll have to say it was experimental. Yeah. And they'll have to just accept that that's a part of being a dad, is you have to experiment sometimes with things.
Exactly.
Okay, fair. You brought up the Olympics earlier, and thinking about athletes and high performers.
Yeah.
Why does this group struggle to be diagnosed?
Yeah. So I think that is one of the pieces I mentioned earlier was when you have these differences, it is going to mean you are going to likely excel at certain things in life. Like, I do think these bodies and these minds were made to, they served a role in society. There was a value to that. So when you find yourself in an area where the way your body exists, moves, can contort, or the way your brain maybe connects patterns, so thinking like autism, like if you can find an area where that is validated and accepted, or seen again as like a whole country can be behind it, well, you're not going to be looked at to be diagnosed. And that's where I wish, for every Olympic athlete, especially once they are finished competing, I wish they would be set up, honestly, with like a health coach to be able to navigate, because all of those things that they were doing without realizing were likely helping them, sometimes exacerbating the conditions, but also helping them cope.
Right.
with those conditions, which I think is where you see the athletes, really struggle when
Can you give
they're
us
done.
some examples? Like, would you say that gymnasts would have EDS or
Yeah.
often?
Yes, often. Yep, exactly that. So I've heard, again, this, I don't know if this is, I've never seen the actual information or data to back this, but I've heard stories of in different countries that they know where there are communities of people with EDS, and they will go to those communities looking for kids then of those families to put them into sports like gymnastics and like figure skating, things like that, where it would benefit you to have very loose ligaments to be able to put your body in those positions. But one of the things that I think is really exciting is, my wife and I, we were just watching the women's gymnastics yesterday, and just how even the body composition of those athletes has changed and how they carry so much more muscle than they used to. And there's been a lot of changes around like nutrition and kind of the image of a gymnastic athlete. But to help the EDS body, because those ligaments are so lax, you need adequate muscle around those joints to help support the joints. So they're less likely to dislocate, to sublux, to have injury. So you have to have this balance of muscle to kind of compensate for that laxity. So I'm hoping that in some sports like that, when we're seeing some of these changes, that we will see hopefully then like less injuries as well, because they are carrying the muscle then that can help support the joints.
Yeah, fair. That's a really good point. Yeah, they're so strong.
Yeah.
Unreal.
It's absolutely incredible. My wife and I just like sit in awe all the time around what they can do.
To generate so much power through such flexible joints.
But that right there is why often they're not diagnosed then, right?
Yeah.
Because back to, hey, your body is excelling. But my whole argument with that is even if somebody is not having obvious signs of struggle with this condition yet, there's still so much to know as far as how they'll help their body later. An EDS body is a little like, I will compare it to like a Ferrari versus maybe like a Honda. Like you can drive it really fast, run it really hard, but then it needs to rest really hard. And you can't just take it to like the local, like Jiffy Lube to get the oil changed. You probably have to take it to the dealer. It just has different requirements to be cared for, where the Honda can just run all day at, on city streets, no problem. It's not the case for the EDS body. And if an athlete were to know that what their body is at risk of, or the things that they were doing in their sport that was actually helping them with their body, then they would know to maintain that or how they could possibly do so when they leave the sport. So.
Good point. Well, they should be calling you.
100% they can.
Totally.
I'd love to. I work with a lot of athletes, a lot of ex-athletes, because for that reason, and then you throw in the ADHD and autism, sports are a really great way as well to, what I'll call it, complete the stress response cycle of the nervous system. So when our bodies are activated for any reason, even if it is a blood perfusion issue, let's say, it doesn't even have to be an emotional stressor, we have to complete the stress response cycle. We have to use up that norepinephrine, that adrenaline that was created to, quote, run from the tiger. Well, sports become a very natural place where you can complete the stress response cycle, where you are also then taught like how to calm your heart rate, calm your nervous system after, things like that. And again, when you leave the sport, you lose that. And if you're not understanding how this not only benefited you in like athletics, but how it benefited your nervous system, how it benefited how you coped with like dopamine seeking with ADHD, or again, coped with chronic sensory sensitivities and nervous system activation from sound, light, as a person who's autistic. That was a big thing that I've figured out I lost from sports after being an athlete growing up. Stepped away and I was like, oh shoot, this was the only way my body knew how to work through any of this energy. And so I had to kind of refine that.
Definitely. Well, something to look out for our ex-athletes completely. What about in pregnancy? Considerations for EDS in pregnancy? Not a situation that clinically I have been in before, supporting someone with this condition who is also pregnant, but eventually I'll see someone, and I'm sure there's lots of people listening who have met someone that they needed to support and didn't have the tools. What should we be thinking about?
Yeah, really good question. One of the things, again, that we talked about earlier is that it's a spectrum and it's different for each individual. So that is a really important part. So my experience may not be someone else's experience exactly. I will say things that we do need to watch out for. Number one is going to be definitely increased joint issues. So for women, period, we actually know that EDS tends to have worse symptoms in women. And a big reason for this is because of changes in hormones. So, which is going to be a big part of pregnancy as well. So we're going to see EDS symptoms exacerbate when progesterone is at its highest, because progesterone is sedating and progesterone is there to relax the connective tissue. Well, great. In an EDS body, you already have like floppy, not so great working connective tissue.
Relaxed.
Exactly. So like increased subluxations and dislocations of joints. Like I found fitness is a big part of my wife and I. She's a personal trainer, so our life here at home. So I still am like weightlifting, but I found that even picking up weights, like I can feel my fingers pulling, like possibly risking subluxation more so. So I have to be careful with like the weights that I'm grabbing then during those times, or like doing like passive hangs or things like that because of my shoulders. But the biggest issue that I've had is probably like pelvic girdle pain. So my hips being like very, very early on, really, really struggling with then kind of some of those pelvic floor symptoms because those muscles are having to work so overtime to help keep my pelvis in line and to keep everything where it is. So like I had to really even work on early on not elongating my stride when I was like walking, or if I'm running, I have to have real quick turnover. Otherwise, I was really exacerbating a lot of those issues and risking like sacral joint subluxation, which is really common in EDS. So that's a big part of it, or even like side sleeping, which you have to do in pregnancy. I've got a lot of my patients who struggle with side sleeping because it can sublux the shoulder. So increased joint issues there. So again, just other things to consider about what may be best for your patient. I've had, and I'll say for myself, some patients where some things can get better. So I will say my issues with blood perfusion and blood volume actually got better because in pregnancy, there is that 50% increase in blood volume. So that side of my symptoms has felt better than it's felt like my entire life. So the big challenge then for me, and that I'll see, is when I'm not pregnant anymore, what happens? And can that then cause a flare of the symptoms, which we know that can happen in EDS, as it can happen. My wife also has multiple sclerosis, and that was one thing we discussed in her carrying, that like a lot of people with MS will do okay while they're pregnant, but then afterward is when the symptoms will return.
Thank you for the insight. I feel so much more prepared, and I'm sure our listeners feel much more prepared to support people with these conditions. I really appreciate your time today, Kalin. We learned so much from you. I'm sure there's going to be people watching who want to reach out to you. Where can we connect with you? Where can we find you online?
Oh, that would be wonderful. Yes. So you can find me at my website at kalinjohnson.com, and that's KalinJohnson.com. On there, you can find information out about my practice, who I work best with, see if that sounds like you. You can also book an initial consultation, which are completely free, which you and I get to sit down for an hour and basically talk about what your wellness experience has been like and see what I can do, see if my different kind of areas of expertise would be apt to support you. You can also find me at Kalin PharmD on Instagram and TikTok as well, where I try to share little insights around a lot of what we discussed today there.
Incredible. So many great insights. I'm so thrilled to speak with you. Thanks so much for being on the show.
Yeah, thank you. It was wonderful.
We'll talk again soon.
Thanks. Bye.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Dizer and at Get Vitamin Lab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.